So, on the topic of pediatric dental sleep medicine, pediatric obstructive sleep apnea is a sleep disorder in which a child's breathing is partially or completely blocked repeatedly during sleep. No different than adult, except for the thresholds are much different. In adults, where an AHI is 5 to categorize somebody as even a mild one, with children it's 1. So for a child to experience just one apneic episode per hour is enough to qualify them as a obstructive sleep apnea patient. This condition is due to narrowing or blockage of the upper airway during sleep. There are differences between a pediatric obstructive sleep apnea and adult sleep apnea. Where adults usually have daytime sleepiness, children are more likely to have behavioral problems. The underlying causes in adults is often obesity, while in children the most common underlying condition is enlargement of the adenoids and tonsils. And early diagnosis and treatment are important to prevent complications that can affect children's growth, cognitive development, and behavior. It is estimated that 12% of the pediatric population suffers from OSA, and an estimated 90% of those kids are undiagnosed. It is also estimated that 60% of the pathologic conditions contributing to the development of OSA are of craniofacial phenotypical origin, and 40% are anatomic. Research has also shown that the contributing conditions can be identified with high sensitivity and specificity as early as 3 years of age. And dentists are perfectly poised to not only screen these patients, but identify a majority of contributing signs during the examination at the hygiene visit. And the symptoms are also sometimes different than those of adults. So during sleep, signs and symptoms of pediatric sleep apnea might include snoring. Infants and young children with obstructive sleep apnea don't always snore. They might just have disturbed sleeping. They may experience pauses in breathing, restless sleep, snorting, coughing, choking, mouth breathing, bedwetting, sleep terrors. And during the day, children with sleep apnea might experience poor performance in school, have difficulty paying attention, have learning problems, have behavioral problems, have poor weight gain, low body weight, called failure to thrive, be hyperactive, experience attention deficit. And it's been documented that 30% of children with ADHD suffer from OSA. And there's a 100% improvement in condition with those patients once OSA has been treated. Causes for pediatrics is most often hypertrophied adenoids and tonsils, but obesity is a common factor underlying this condition in both children and adults. As the rate of obesity is on the increase, we're seeing this factor more and more so in children as well. And the other underlying factors could be craniofacial anomalies such as narrow palate, retruded mandibles, narrow mandibles, and neuromuscular disorders, as discussed before. And the risk factors besides obesity for pediatric sleep apnea include Down syndrome, abnormalities in the skull or face, such as Gell class 2, retruded mandibles, narrow palates, cerebral palsy, sickle cell disease, neuromuscular disease, history of low birth weight, family history of obstructive sleep apnea, and the complications have some serious implications, such as ADHD, obesity, hypertension, failure to grow, heart problems, and even death. It's been documented that the sudden infant death syndrome, SIDS, has this OSA factor contributing to it.
So prevent is, I don't want this to ever really occur. If I can find it early enough, we might have an opportunity to make this person's life better for the rest of their life. At the very least, we're putting them in an opportune position to maintain health for the rest of their life, and in conjunction with that, it's a great smile that functions well and So what's not to like about the idea of preventing? The next I thought was that, you know what, we're going to miss some people and we're going to try to control them. Control strategies, probably the most common ones that are used, are CPAP and mandibular advancement appliances. The commonality of those is that the utilization of the appliances, both CPAP and mandibular advancement appliances, are pretty darn low. People just don't like using them, and for sure they don't like using them for a long period of time. The other link is that they're really designed, in my opinion, for adults. Now, while you can use CPAP and an oral appliance that protrudes on a child, really what I want to do with kids is make it go away rather than maintain that forever and ever. You see, a kid on CPAP is making it worse for themselves for a lifetime, given the headgear effect you get from the appliance. So yes, it fixes it for a moment, but I think anatomically it's problematic. So my control strategies are usually reserved for more adult patients. Resolve, make it go away. Once again, on an adult patient with wear in their teeth and erosion on their teeth, and we made a control strategy, a night guard of some form that made them feel better, I do my best to try to make that night guard go away. How can I turn you into the night guard? Once again, in children, we're going to try to do that in a way, but we're going to try to do it before the disease process gets so severe. And so I hate finding kids that have apnea. It means we waited too long. We missed a lot of the signs early on. But I'd love to find the signs and symptoms, clues, before the real onset of the big time disease takes place. And then making them better at that point, I think, does the best for the child. But there's going to be occasions when we actually have to resolve and make them better from the point of apnea. So prevent is my key in kids. Let's find them early, get to them early. I would still have that 6-month visit with parents. And the discussion would also then be able to go to how was breastfeeding? Did they latch? Did they have the tongue tie? Some of the nutritional hints that we give out in order to try to get them introduced to harder foods early. It's called baby-led weaning. Just trying to see if the child is snoring, mouth breathing, or having witnessed apneic events early on, because we know that the worst period of time for a child from at least a neurocognitive standpoint is early issues. So the earlier we can find it, the better. And so I think that 6-month visit makes a lot of sense today. Well, what are the downsides? What are the disadvantages to not being able to prevent it? And there are a number of them. We call them autonomic dysregulation, which means kids are more sympathetically active than they should be at night and during the day. And this doesn't have to be full-blown apnea. Remember, little events can cause the excitatory nature of the body while you're asleep and keep you from actually getting the benefit of being asleep. So the sleep-disturbed breathing issues in kids can create alterations in this autonomic nervous system function, create too much fight or flight all night long, and not let that soothing, healing, parasympathetic mode of sleep to take over. In kids, it ought to be at least 4 times the amount of sympathetic activity at night. That's why the body and brain can heal itself so well. That's why kids learn so much early on, is because of the amount of sleep they get and the healing nature of it and the memory-inducing component of it as well. If you don't get into those types of sleep, it also facilitates both metabolic and cardiovascular types of issues. So a metabolic syndrome patient can be associated with this. And I usually say any medical problem that you can think of for an adult that's associated with apnea, we can probably find something in a child as well. When is it most damaging? It's actually most damaging during developmental periods of time. The unfortunate thing for us as healthcare practitioners is that we don't know when those periods are. We can make guesses based on other people, but for the patient sitting in front of us, we don't know specifically if it's going to happen next month, next year, or it already occurred. And so these moments in time where it's important that they're breathing well, sleeping well, we are unaware of when it's going to happen. And so to tell me they're going to grow out of it doesn't make sense to me at all. Really, in fact, I would say they mostly grow into these problems rather than out of the problem. The answer, or the question to ask always, if a person wanting to do orthodontics later when they can take advantage of a growth spurt, or an ENT saying that they'll grow out of it, we don't need to take out the tonsils and adenoids. The question is, we know if they're having sleep-disturbed breathing issues, that it's a bad thing during certain developmental windows. Can you tell me if they've already gone through that? Or are they going to have it happen in the very near future? Because if I know that, then I'll understand your logic. But what we're really finding is these kids really don't grow out of it that well. Really, most of the kids that end up having, where they divided them into 2 groups, they ended up having about 50% of the problem continuing on, even though we were watching them and felt like they would actually grow out of it. So think with me about the numbers here. You take your child in, the physician says, I think we'll just watch when they put them on Flonase, we're going to keep an eye on it. I think they're going to grow out of it. Well, 2 things can happen. One is they don't grow out of it, in which case, in this particular study, 4 years down the road, they've continued to suffer. The second is they do grow out of it. But the question you have to ask is, when did they do it? Because if it wasn't as they walked out of the door of the physician's office, you don't know what developmental window the child happened to go through. And the overall impact of that may be rather severe. We simply don't know. And I think that's too much of an unknown. So what's great about dentistry is we can find these problems really early on. We don't have to wait around that much in order to find the issues. So finding problems, detecting them early is something that dentistry can do quite well. Well, when in kids can we start seeing these issues? And I would suggest to you that we can start seeing them at about the age of 4. So in a 4-year-old kid, you can start seeing and detecting these issues by what? By changing in the dental structures. Now, I would tell you there's a study that was done out of Stanford where they were actually working on 2- and 3-year-old kids. So it can be found early if we just simply look for it. If we do find it early, then we can make craniofacial alterations that may assist the breathing. But if we choose to wait, what this study tells us is that it actually makes it more difficult down the road. It makes the breathing more difficult, it makes the resolution more difficult, it makes the craniofacial problems more difficult. So my message has always been, when asked, when do we begin treating these kids? My answer is always, whenever you figure out the problem. We don't wait around and say, well, I got a growth spurt coming, or I think they'll grow out of it, or let's give them this for 6 months and try whatever. I think we ought to start making some effort to make it go away right away. So if that's true, if the key is finding them, how do you go about doing that? What do you need to do to find out? And I think the key there, the idea is you got to start looking for them. And beyond looking, you also have to start listening to the parents. And the areas that we'll be paying attention to are medical, sleep, and dental. So detection comes down to medical issues. This young lady had early onset hypertension, early onset diabetes, and she also had obesity as a part of the equation. Now, interestingly, we think, okay, obesity is a dependent factor. It drives the apnea. But in reality, it's an independent factor in most cases where it's an add-on effect. The real effect, the real problem is craniofacial. You add on the obesity and then it becomes a big problem. So studies have actually utilized the metric of weight and been able to eliminate that as a confounding variable and found that really craniofacial is what leads the way. So what am I listening to from my patients? What indicators might they tell you? What would the parents say? Well, we have a little questionnaire that we give out, and one of the questions that's important is, do they wake up tired? Do they have reduced energy throughout the day? Do they tell you about morning headaches or their head hurts in the morning? One of the key factors is, do they breathe through their mouth? And it doesn't even have to be snoring to be harmful, especially if they're doing it throughout the day. I just was lamenting the fact with a patient I had in my office that I remember now in hindsight, my mom constantly saying, close your mouth, close your mouth, close your mouth. And I grew up a mouth breather, and I still today suffer some of the effects of that. There's also emotional or behavioral types of issues, and the ones that jump out to most of us are ADHD, ADD. Anxiety plays a high-level role in many of these patients, especially if the airway component kicks in when tonsils and adenoids start enlarging. And the final thing that you may see from a medical indication is a reduction in size, height being the main one. Human growth hormone is released in deep sleep, and so inadequate deep sleep would be met with a smaller child, one that doesn't quite hit the growth curve. From a sleep standpoint, when you ask the parents questions about their sleep, the easiest one to say is, does your child mouth breathe while they're asleep, snore while they're asleep, or have witnessed apneic events? Typically, we follow up with, is it habitual, meaning 3 nights a week or greater? Those are sort of the factors utilized or questioned most often in scientific studies. If they wake up throughout the night, they are getting a fragmented night's sleep, so they're not really getting the benefit of being asleep throughout the night. So kids that make you come into their room or vice versa, they end up sleeping in your bed throughout the night, are usually having fragmented sleep. And even though they may sleep with you, you can usually tell me stories about them rolling on you, smacking you, kicking you, and not actually getting the benefit of sleep. An easy way to think about it is, if they aren't paralyzed during sleep, they don't move, then they're not getting any benefit from being there. Bruxism is a dental sign that they may be getting fragmented sleep or having airway issues. Sleepwalking, sleep tears, sleep talking, or night sweats are all deep sleep types of issues. Thumb sucking, there's one study that says continued utilization past what we would consider a normal period of time. That thumb sucking at that point in time is probably a way to improve their ability to breathe through the nose. If you think about it, when the thumb goes in the mouth, the tongue activates and therefore it's out of the airway, and it also creates tone in the airway. So there's a reduced ability, or there's an increased ability to breathe through your nose effectively when you're thumb sucking. If you reread our literature in dentistry, and whenever they say the words that it pacifies them or calms them, think that's what breathing does for them, then you'll probably see the logic behind that. Bedwetting beyond what we would consider normal, and normal is still up for debate, but let's call it 6 to 8 years old, somewhere in that range would be abnormal. And then, as I already mentioned, restless sleep will be a confounding factor as well. They're not getting the benefit of being asleep at all. All right, so that's what you're listening for when you start asking questions to a parent. What are you looking for when the child actually sits down in your chair and you start doing a dental exam? Well, the neat part is, if you do a comprehensive evaluation, you're going to find these things. So your normal comprehensive eval shouldn't have to change at all. Now, the questions may change, right? So you start seeing some things, and then you ask different questions. That's a possibility. But really, it's just looking for things that you're already looking at, just seeing them with new eyes and creating a unique experience for the parents and for the kid. So what questions or questionnaires do we ask?
The pediatric sleep screening forms can be accessed from within your resources section of your dashboard, and they're available in both English and in Spanish. And when you access them, it simply requires some basic demographic information: the patient's first name, last name, date of birth, their gender, and the date you're accessing this form, which is very important because you have to document that you've screened your patients. And this is a great compliance tool that you can archive in your that's one, archived in your dashboard. Number two, can also be downloaded and archived in your practice management software under the patient's chart, and that kind of documents that you've screened your patient for sleep apnea. And this tool is, for the most part, a patient-directed child-related questionnaire that evaluates 5 major domains, including bedtime problems, excessive daytime sleepiness, awakenings during the night, regularity and duration of sleep and snoring, and is divided into 5 major sleep domains, and it is age selective. So there are 3 different forms, one for ages 2 through 5, another one for ages 6 through 12, and another one 13 through 18. And as you will see a little bit later, they're very specific for that age because certain symptoms appear which are very age specific. So these are very targeted, very accurate screening tools with a high sensitivity and high specificity for a child suffering from sleep apnea. So as you can see, it goes over if the patient has any problems at bedtime, do they have any problems going to bed, in terms of sleep latency, excessive daytime sleepiness, do they take naps, do they feel sleepy, do they wake up a lot during the night, do they have nightmares, which is a problem with a REM disorder, and if they have trouble getting back to sleep. And it also documents what time does a child typically go to bed, and when they wake up in the morning, do they actually feel refreshed or not, and if they snore. And once you've filled out the screening form, then you can actually save and download and upload to your desktop into your practice management document center in your patient's chart. You can also select based on the age of the child. As you will notice, the questions change. And as you will see a little bit later, that the age group of 13 to 18, which you will see a little bit later, will have different questions. But this is great for the parent because it's the parent that's filling out these forms, and you can actually have these forms available for the parent to fill out on a tablet or a desktop in your office, or you can actually email this to them. Since this is a downloadable form, you can actually download it and email it to your patients, and they can fill it out before they actually come into your practice. But as you can see, when you're evaluating a child that's 13 through 18 years of age, most likely around age 17, 16, they might start driving. And if they have an undiagnosed sleep apnea, that could be a pretty hazardous condition to be driving in, especially when they're tired and sleepy. Especially in the morning going to school, if they didn't have a good night's sleep, they could be tired and get into an accident, and that's not a good thing. So we do want to screen all our pediatric patients and have the parents fill this out. And of course, you will have your own examination form that's specific for pediatrics. And when you click that evaluate form, or when the patient's parent clicks the evaluation form, it will take them to a dashboard where they can actually then enroll the patient as a patient into your practice.
The hygienist is the one that needs to be trained. he or she should be evaluating every one of your patients, both adult and children, for airway types of issues and airway anatomic types of things, medical issues, systemic issues, and craniofacial issues. And they ought to create an awareness before you ever enter the room. So that form ought to already be filled out, all the boxes checked. And then when you come in the room, you can limit your discussion to just the few things that happen to be checked and try to pair that information with what you see in the child's mouth as you go in for the exam. Now, the exam is the same, whether it's in a child or adult, so nothing changes in the examination. And interestingly, if you look at an orthodontic evaluation or examination and all the things they gather, it's an airway evaluation. They, in this study, started looking at photos that they took of the face and measurements they made, the arches that they were looking at, the bite register, the malocclusions that they paid attention to, the depth of the palatal vault. And when they added all that up in the end, they said, you know what? In an orthodontic office, by just looking at the dentition and the face, we can differentiate between kids that have sleep-disturbed breathing issues and those that do not on a pretty high probability. So dentists are really good at it. We just have to, and we're looking at the stuff we need to look at. We just have to be aware of what we're looking at now. Okay, so the easiest way to think about this is that if you do a dental examination and a cancer evaluation, you've looked at everything but one structure that we need to pay attention to in airway. So you've looked at all the dentition, you've looked at the face, you've looked at the tongue, the floor, the mouth, the soft palate, the tonsils, and the oropharynx. So you've done it all except what? Except one thing, which is the nose. And we only ask to do 3 things on the nose, and they're very quick to do. And I'll show you in a moment what it is. So I'm not going to change your exam at all. Your exam is going to be exactly the same. And your hygienist exam is going to be exactly the same, except for the nose. And it takes just a second to do. So this is not going to change your practice to start helping find these kids. In our Airway Pros workshop, we actually have a form that we walk through, but it's simple. You just start on the outside, work inside. And I'm going to show you tonight on how we do this exam. So different questions, depending on the age of the patient, depending on the symptoms of the patient, but the examination is exactly the same. So we start on the face, and just like a cancer exam, you start on the face and you're looking for lesions. In the facial exam on a kid, if I said to you, what facial contour, shape, would be the most prone to having sleep-disturbed breathing issues, the answer is dolichofacial, or narrow vertical faces. We in fact call them an adenoid facial type. So long vertical facial face types, most prone. Does it mean that somebody that has a square jaw, a kid that has a squared off jaw, is not going to have apnea? And the answer is absolutely not. Everybody can have an opportunity to have apnea or airway issues. I'm just suggesting to you the highest rates happen to be in this facial type, and this face type tends to be driven by the airway problem early on. What other things are we going to see just straight away looking at the kid? Well, you can see if they're maxillary deficient as well. When they smile, you don't see the teeth as they go into big smile. You can look and see if they have vertical maxillary excess, too much maxilla exposed when they go into big smile. And finally, the other thing that we're evaluating is buccal corridors. When they smile big, you see excessive buccal corridors. One of the keys here is if the buccal corridors are narrow, that means the palate is narrow, the maxillary arch is narrow. The palate is the connecting point between the oral cavity and the nasal cavity. And so anytime you see a narrow upper arch, you know that you're going to have narrow and small nasal volume. And small nasal volume equates to difficulty nasal breathing. And nasal breathing is the key to overall health. Interesting study done by an orthodontic group looking at some data out of the UK. And what they found is that on these kids they had followed for their entire life, that at 15 years old, and these are lots of kids, 1,700 kids with sleep breathing issues, 1,800 kids that did not. They ruled out any kid that had surgery, ortho, anything like that. They did laser facial scanning on them. And what they found is that that narrow dolichofacial type is highly prevalent in kids that have breathing issues. I already said that. We also said that they are more retrognathic. We saw that, we'll see that in a moment, less mandibular growth. But what drives it? What's the key? The key they really found was the nose was narrower and the nose was set more further back in the face, meaning there were deeper nasolabial folds on these kids. Now let's say it from a structural standpoint, a skeletal standpoint. Narrow noses and narrow deepening of the nasolabial folds, what does that mean? It really means the maxilla is too small. So that's the driver for all of this. Our kids that breathe better had bigger noses, more prominent mandibles, cheeks, and foreheads compared to the sleep-disturbed breathing kids. Now the kid actually is sitting in the chair and you can get a glimpse of them from the side. 4 things we want to look at from the side. One is to try to determine where the maxilla happens to be positioned. Andrew's line is one that I use. It's a line drawn off the glabella of the forehead when the eyes are looking out directly to horizon, not tipped up, not tipped down. The central incisor should be on that line. So Larry Andrews years ago told us that central incisors really ought to be right on the line. When they're behind that line, we know that there's a deficiency in the maxilla. When they're in front of the line, it is more prognathic than the maxilla. Remember, the head posture is key because it's going to throw off where glabella is in relationship to the central incisors. So a postural position is important in these kids, and they obviously have to smile during that photograph to be able to see where the facial surface should be. In looking at his orthodontic patients, he limited them to adult white females, so he took out racial variations. He said that the ones who had the attractive smile with the good profile associated with it 93% of the time, the central incisor landed, the facial surface of the central basically landed on that line to glabella. When he looked at his orthodontic patients that were coming into his practice routinely, only 20% of the time did the tooth fall in the appropriate position. Most of the time, the maxillary central was significantly behind the line, meaning they were not only mandibular retrognathic, but also maxillary retrognathic as well. So maxilla evaluated first, mandible second. I think everyone knows how to evaluate a mandible. Now, the things you may not be evaluating in the sagittal perspective are the head posture. I want to make sure the head is sitting up right, because forward head posture is associated with people that have airway issues. We know kids that need tonsils and adenoids removed tend to lean their head more forward. People that have apnea even further forward in order to breathe. As you lean forward, the airway opens more. And finally, where is the tongue? And this is interesting because a tongue can be habitually postured low, but more than likely it is either tongue tied or the patient has such a small skeletal structure, they can't get it into the mouth. And so either way, it falls down below into what we call the cricomental space. The cricomental space, if you went from cricoid cartilage to intermentum and then drew a line up to the neck, it needs to be about 1.5 centimeters. Now that's obviously a measurement in adults, but what we're looking for in kids is there needs to be a space there. It shouldn't be all constricted and restricted with the tongue like in this young lady. So just looking from the side on this young lady with no other information, you can tell the tongue is sitting low, and now all you have to do is ask why. And the main answer is she doesn't have enough room and she's tongue-tied, or both, because tongue-tied individuals tend not to have enough room. The tongue didn't allow the arches to form. So it's not unusual that when we look in the mouth that the arches are actually extremely narrow. The next examination is of the nose. 3 things we're going to be looking for here. And for those not used to looking in a nose, as we go into the nose, on the left side of the screen is the septum. Right in front of you, that kind of roundish structure, that's an inferior turbinate. And you'll notice the tissue looks like healthy gingula. So it ought to be that light pink color. 3 things we want to know: is the septum deviated? And all I do is take my finger, put it on the nose, and pull up and look inside. Is the septum deviated? Is the turbinate inflamed? So instead of that nice pink color that we saw, it's going to be red and raw looking. And the third thing is I ask the child, take a deep breath through your nose, and if the nose collapses, either on the outside or inside, up higher near the cartilage, we call that nasal valve stenosis. Nasal valve stenosis is probably the number one missed thing that I see when I have patients come into my practice, referred especially from sleep physicians. They'll say they have apnea, can you make an appliance? And in fact, all the problem is their nose is collapsing. Something like a breathe right strip or a nasal dilator can do wonders for these types of patients. If we look at data about the importance of nasal breathing, this is a comparison of severe sleep apnea, mild sleep apnea, and just nasal, essentially disused patients, ones that don't breathe well through their nose. They found in terms of inflammation measured by oxidative stress, that in fact all of them were equivalent to one another. And their conclusion was that it's the lack of nasal breathing that plays the important role in the pathogenesis of apnea. You got to be able to breathe through your nose. So bigger maxillas, noses that are open and able to breathe are key. Just as an aside, when we're evaluating septums and seeing septal deviations, a couple of quick studies actually are out there right now. They both show that children with septal deviations early on in life, and one study was 100 kids and 40 controls, that these kids, if you went in and expanded them, that the septal deviation fixed a little or a lot. It's basically telling you that deviations of the septum are rarely a baseball hitting a kid in the nose. They are routinely a lack of space as dictated by a constricted maxilla. Finally, we know that if you can't breathe effectively through your nose, that in fact you'll grow differently. And how differently, what direction will be different, that is still could be variable depending on many things, when the problem occurs, what your genetic predisposition happens to be. But we know it's going to be class 1, 2, or 3, but the maxilla and the mandible will always be set back. They'll always be more retrognathic than they actually should. And the face is going to have a higher level of dolichofacial tendencies. What about dentistry and the dental examination that you're doing? Well, interestingly, a lot of the things that we see in children could be linked to not breathing effectively through their nose. Caries rates are higher in kids that are mouth breathers, and it's simply because we changed the pH of the system into a system that is more prone to have decay. Periodontal disease in kids, numbers of studies have shown that kids with mouth breathing habits or snoring habits tend to have worse plaque index, gingival index, higher level of periodontal disease. We've also done the opposite, which is fix those problems, doing tonsil and adenoids or expansion, and found in both of those different treatment strategies, the periodontal disease came under more control. Erosion or reflux on the teeth could be the negative pressure associated with the breathing event, sucking up the acid onto the teeth. Bruxism could be triggered either by the erosive event or by the airway event. And so grinding of the teeth is always on our list of things to be looking for when we're thinking about airway consequences. Malocclusions we've already reviewed, and the part of the thing that I want you to keep in mind is that we rarely think of the maxilla as part of a malocclusion, but it really is. Think with me, if the maxilla is constricted and restricted in its AP growth, and a patient and your orthodontist says they're just a little class 2, but the maxilla really is 3 millimeters deficient of where it should have been, then they're a lot class 2. And more importantly, Class 1 doesn't necessarily mean class 1 anymore. If everything is set back in the head, the way that we just saw in the research out of Japan, then they're really retrognathic, bimaxillary retrognathia. They're not class 1 normal, so we need to pay attention. Missing teeth or blocked out teeth are going to create a constriction, or extracting teeth, theoretically, if you don't let the molars come forward, could create that constriction as well. Functional wear, if you have a constriction or restriction of the airway, many times it's difficult to chew without running into your teeth and hitting your teeth. And finally, orthodontic relapse. When we expand, but don't keep the expansion, start thinking, why not? And it usually is the patient never closed their mouth, started breathing through their nose, could be the tongue, could be the nose. What other things are we looking for during a dental exam? Well, the shape of the arch form, the depth of the palate, any tori they may have, both in the upper and lower. Do the teeth tip lingually, so that the teeth look normal as far as tooth-to-tooth interdigitation, but in fact, the lingual inclination is what gives you the illusion that everything's normal. It's simply a camouflage. Occlusions like deep bites, open bites, both anterior and posterior, could be related to it, and malocclusions, I think, are the fairly obvious one. Bruxism, we already said, is pathologic and should be marked as something that we would say that could be an airway problem. Now we come to the tongue, and we have to evaluate the tongue for cancer. We have to evaluate the floor of the mouth for cancer. And because we're looking at the tongue already, let's make some different notes. We would say it's big, it's scalloped, it's reddened. But the one that we always start thinking about is it tongue-tied? And for me, when I'm feeling the floor of the mouth for cancer, your hygienist can do the exact same thing. I just run my finger past the frenum. Everyone's going to have this attachment for the most part, okay? When you run past it, if it feels elastic and it doesn't really feel like it restricts movement at all on the patient, more than likely it doesn't. But if there's body to it and substance to it, we know that these frenum are actually more collagenous in times when they are really tongue-tied. They're a different type of tissue. It feels different to you. It's not elastic like the other. So if I get a hint that that's the case, then I start looking in more in depth. I personally classify tongue ties into class 1 and 2, which are both anterior tongue ties. Class 1, the frenum goes all the way to the tip of the tongue. Class 2, the frenum stops short, but goes towards the anterior. So I can see that it's traversing towards the tip. Class 3 and 4 are both posterior tongue ties. That means the fibers are going to go deep into the body of the tongue. And these, I think, are the more damaging of the two, mainly because we don't see them, we don't catch them as often. You see, if a kid comes out in their class 1 tongue tie, everybody, the lactation consultant, the nurse, everybody sees it, and everyone knows what to do about it. But when a kid comes out and has a class 3 or 4 tongue tie, they many times are not caught. How do we find them? Remember that 6-month time that the kid comes in? You ask about latching. How do they breastfeed? A kid that has a posterior tongue tie is going to have difficulty doing that, simply because they can't engage well enough to bring the nipple into the mouth because the back end of their tongue won't rise effectively. The class 3, you can still see the fibers as they go deep, and the class 4 tends to be hidden, and they tend to be really big tongues, thick tongues by the time you see them. The other way to find a posterior tongue tie is have them actively engage, like pull up on the tongue, and you'll see where the fibrous attachment is because they create this little dimple in the dorsum of their tongue. Now they can move the tip of the tongue, they can move the sides of the tongue. It looks like they have normal movement. It's the body of the tongue that actually can't go where it's supposed to. The other thing they do is they sometimes cheat. So when in a moment I ask them to move their tongue to show me how much they can move, if they bring the floor of the mouth up above the occlusal surfaces of the teeth, that's kind of cheating. It means they don't have as much mobility as what you're already measuring in the mouth. The way that I routinely measure mobility to see if it's a functional tongue tie, I have the patient open as wide as they can, measure that amount, and I make them put the tip of the tongue on the roof of their mouth, and they ought to be able to get to 50% of whatever that normal measurement is. So I had a lady earlier today who went to 66. It was amazing. But she could only get open to about 28 millimeters when I had her tongue on the roof of her mouth. So that was significantly tongue-tied, and we needed to get something done about that. Another way of doing it is the way Audrey Yuen showed in one of her papers, and it's actually opening as wide as you can, and then moving the tongue towards the teeth without closing at all. So do not close and move the tip up. And how close you can get is what she's measuring there. The compensation is what throws it all off, though. So if they're compensating the whole time, then you know the number is actually lying to you, essentially. And the last thing I wanted to remind you of is many of these deep tongue ties end up being really thick, big tongues. So the macroglossia patient that we always deal with, both kid and adult, start thinking of tongue tie in those patients. The final part of the exam is the back of the throat. We got to check that for cancer, and your hygienist does as well. In the back of the throat, what can we see and what do we measure? Well, the first thing we're going to do is an oral pharyngeal exam. We're going to look at the tongue size relative to the pharyngeal size, and that's called Mallampati scale or modified Mallampati scale. Also, some people may refer to it as a Friedman maneuver. Class 1 is I can see everything. Class 4 is I really only see your hard palate, and 2 and 3 are sort of in between. 2, I can see the uvula. 3, I can barely see the base of the uvula, so I'm seeing soft palate in the 3. Then make some notes. Tell me it's red back there. Redness can be from snoring. Some people actually, when they open and you just put anything on their tongue, their soft palate obstructs their airway immediately. So write that down. Tell me if the soft palate seems longer than what you would have ordinarily anticipated. And then tell me a little bit about the uvula. There is no grading scale for a uvula. Just tell me it's big, it's red, it's swollen, it obstructs. Just give me some indicators as to what's going on with the uvula if it happens to look outside the norm. And the final thing for kids and adults that I look at is the tonsils. And we grade them by the closeness that the tonsils have to one another. And 0 is they're gone, they've been taken out surgically. And then 1 is you can barely see them. And 4, they essentially touch. And it depends on the ENT as to how they want to do it. But you even got some ENTs that will make the patient gag, so they see where they come together. And their assumption is that's what's going to happen when they get relaxed at night and fall asleep. And they grade them during that activity. So let's go through a patient really quickly and see if we can go through the exam and show you what our protocol is past the exam. So this young lady came in when she was 5 years old. What was I listening for? I was listening for the fact that she snored since she was born, whether she was congested or not. She grinds her teeth every night, and it goes throughout the night. She has bad breath and is a mouth breather. But her mom described her as a good sleeper, the good sleeper of the family, at which time I said, I need to see your other kids, because good sleeper she's not getting good sleep. She's just not bothering you. Most parents will call the good sleeper the one that doesn't get up and get in their bed. She's been using a pacifier since forever, and they started trying to wean her off at 2.5. She wanders around in bed. She has ear infections, and the physician said, I think she's got allergies, but they've been tested and she has no allergies. What am I seeing? I'm seeing that she has a lisp, that she has an infantile swallowing pattern, which means she moves her tongue back and forth as she swallows, rather than swallowing food the way that she should. She has a very large tongue, a very scalloped tongue, and she has pathologic wear on her teeth. I'm also seeing some excessive overjet and overlap. I'm seeing a low tongue posture when I look at her from the sagittal perspective. I look in and I see a class 2 tongue tie on her, class 3 plus tonsils. And when I look up her nose, I see inflamed turbinates. So what is our protocol? Our protocol is what? Ask questions, do an exam. And then we always like to gather data, because we like to do airway-directed planning, which means show me data on this kid. So what data do I need on most of these kids? Well, the thing I like to get are 3 things. First is what's called a CPC. I'll show you in a moment. It's a way of measuring sympathetic activity. Remember, most kids don't have apnea. If you wait around for a kid to have apnea, you're not treating any of them. So I want to see how sympathetically active they are throughout the night. The second thing I want is a CEPH or a CBCT. I would prefer CBCT, but some kids that move around too much, you're not going to get it. You're going to get a CEPH. So this is a 5-year-old. My sort of cutoff is 7. I think by the time they're 7, they ought to be able to sit still long enough to actually make a CBCT. And the last thing I want is a video of any of the activity they have done by the parent. Snoring, moving, grinding, whatever it is. Give me a video of it, and I'll show you in a moment why we use that. So that's what we did with her. Got a CEPH, got a CPC. And for those of you not familiar with this, the light blue, the white peaks, those are the times she was in parasympathetic sleep throughout the night. Down below, that's sympathetic, that's activity. There ought to be 4 times as much white as there is anything else on that screen. And you can see that her sleep is significantly fragmented throughout the night. The CEPH would indicate that she has large adenoids, large tonsils. It shows that. It also sort of shows the craniofacial changes that are occurring already in this young lady. Why the video? Well, on this, I've outlined where the adenoids are, and they almost touch the back of the palate. The airway was severely constricted. The child snored all the time. Is already having craniofacial issues and change. I thought this was a no-brainer, to be honest with you. But the mom happened to videotape the kid. Okay. So what did we find? Well, what happened, I referred him to the parent to an ENT. The ENT said, I think we'll give him some Flonase and we'll watch him for 6 months and we'll reevaluate and we'll see how they're doing. And kind of the classic answer that many of you have gotten on patients that you've taken ENTs. Once the mom said, whoa, time out. She handed the phone to the doctor and said, this is what I see, and I see it every night, and in fact, this was a good night. The physician can watch this and use it as essentially a sleep study to validate why they want to go in and do the surgery. And so after viewing it, the ENT scheduled the surgery for the mom, and the child was discharged today. So who are the main referral services we have? I'm going to send them to an ENT for evaluation of tonsils, adenoids, and turbinates. I'm sending to someone, I wrote down, instead of orthodontists, I wrote down orthodontics. Could be orthopedics, also would be another way of thinking of it. I need somebody to change the craniofacial direction that most of these kids are growing. If you come to me and say, my child needs their tonsils and adenoids out, I'm going to tell you they need orthopedic intervention, because breathing against that structure has changed them somewhat. And so I want to assist. Now, it can be a little or a lot. It depends on the child. But somebody needs to intervene. And who does it is dependent usually on the community and who's comfortable. So if it's something you're comfortable with and you're trained in doing, then you may be that person. The final person I think that's really the most important that we constantly forget is a myofunctional therapist, because you've got to get someone to get the kid to close their mouth and breathe through the nose and validate that it happens. And if they're tongue-tied, which might be the reason for all of this happening, you've got to get that taken care of as well. So we would include a surgeon along with a myofunctional therapist. The final one is a sleep physician. And my old protocol was find a kid, send them to the sleep physician. And what I found was that was a barrier to care. Because most of the time the sleep physician found no apnea and said they have nothing wrong with them, and that's wrong. They do have something wrong. It's just not apnea. So I do not send them to the sleep physician. I leave that decision up to my ENT, whether or not they think it would be appropriate or not. So why are we so focused on the myofunctional therapist? New study that came out this year, it's a systematic review. It said that greater apnea reduction occurred when you did what? When you did tonsils and adenoids and orthodontic treatment. So this is not an either or type of situation. I think if you ask me the question, using once again our Q&A button, if you ask me the question, what would you do or how do you treat them? You do both. If it's appropriate, you do them both. You don't try to work your way around one or the other. Do them both. The problem is many that you do both on get a reoccurrence of the problem down the road. And interestingly, what we found is in order to avoid that reoccurrence, myofunctional therapy is the key. You have to be able to do something to train the system to be used correctly.
Children with obstructive sleep apnea syndrome may have narrow and long face with large tonsils and narrow upper airway, maxillary constriction, and some degree of mandibular protrusion. Increased nasal resistance may lead to unfavorable facial growth and to the development of dental malocclusion. When these conditions appear in early life, they can cause deformation of maxilla, affecting its cross-sectional development. You can also usually predict by the angle of the mid-palatine suture, soft tissue outline, where the nasal septum would be and how the septum deviation will decrease nasal flow and force the child to breathe from the mouth. It's a vicious cycle that unfortunately contributes to adult OSA. But the management of these patients, of these pediatric patients, the first round of therapy that's been recommended is removal of tonsils and adenoids. And the second recommendation is for maxillary expansion, those children that have narrow constricted maxillas. And oral appliances are preferable, but the issue with oral appliances is that with developing occlusion, with developing jaws, oral appliances can actually retard the growth, the skull growth in some children. And rapid maxillary expansion is an orthopedic treatment procedure routinely used to treat constricted maxillary arches, and also a potential additional treatment in children presenting with sleep disorder breathing. OSA may evolve during childhood before becoming clinically evident later in life. The importance of these observations lies not only in the potential to treat the underlying craniofacial abnormalities, but more importantly, raises the possibility of early detection and treatment of children at high risk of developing OSA, may prevent the disorder in the future. Since maxillary constriction is a feature of chronic nasorespiratory obstruction, rapid maxillary expansion has the potential to play an important role in such a preventive strategy. The quality of sleep of these children improves tremendously after rapid maxillary expansion, regardless of the severity of the respiratory obstruction. The early detection and treatment of children at risk of developing OSA may prevent the sequela of this disease. With RME, there's an increase in sleep efficiency and total sleep time in children without SDB. Rapid maxillary expansion treatment also induces widening of the maxilla and corrects posterior crossbites, improving maxillary and mandibular dental arch coordination of Class 2 and Class 3 malocclusions. And dentists who perform a comprehensive head and neck examination should be in a unique position to identify children with malocclusion that can lead to development of sleep disorder breathing and refer them for further evaluation. Rapid maxillary expansion is a useful treatment option for improving quality of sleep even in normal children without SDB, but who are at high risk of developing SDB due to their craniofacial morphology. But positive airway pressure therapy is not without its own set of complications. It's actually been shown to retard mid-face growth of children at a rate of 1 millimeter per year use, and can develop into a skull class 3 profile over extended long periods of time use. And medications such as topical nasal steroids, like Rhinocort, Flonase, some of the allergy medications have been used to treat some of these kids in the hopes and the attempts to improve nasal airflow. So what questions do you ask parents? Well, it's as simple as asking them if their child snores, or have they or someone else observed their child stopping breathing in the middle of their sleep, or having disturbed sleep, nightmares. That's on a regular basis. How about paying attention in school or even at home? Children acting out. What about learning difficulties? Is there a family history of obstructive sleep apnea? And now this is important from a dental standpoint, bruxism. And that's a big one. How about bedwetting? In the sleep apnea program, in apnea. And as always, if you have any questions, please feel free to email us at info@apnea.com. You can also log into your dashboard, ask our artificial intelligence assistant, Cato. You can also access this in the FAQ section and also in the supplemental data in the resources section of your dashboard.